All right. So I think this is a go. So welcome, everyone. Thank you for joining me tonight. And I wanted to welcome you to the Foundations for Bone Building and focusing on a lifestyle approach to osteoporosis and bone health. And before we can really talk about what's wrong with bones, we have to talk about what's right with normal, healthy bone. And so I wanted to, hang on one moment, I'm just going to hide our thumbnail. There we go. I wanted to talk about what's the makeup of a healthy bone, because some of these terms are going to come up again. And most bones are going to have a structure of a hard outer shell that we call cortical bone or the cortex. And the inner core of the bone is trabecular bone, which is characterized by I wouldn't necessarily call it a soft inner mesh, but it is a protein collagen matrix in which the mineral composition, which is mostly calcium and phosphorus, which is also called hydroxyapatite, is embedded into that protein collagen matrix. So we get the benefit of strength from having all those dense minerals embedded into a protein collagen matrix, which provides us with the flexibility that bones need. Because when you think about it, we don't want bones that break, we want bones that bend, right? And if we're going to talk about healthy bone, we also need to talk about healthy bone remodeling, because many people don't realize that bones are not static entities. They are broken down and formed again. Bone is constantly being broken down and it's constantly being reformed. And the process of the bone being broken down is referred to as bone resorption. And the process of bone being rebuilt or formed to fill that space is called bone formation. Now, there are two very particular cells in the bone itself that are responsible for this resorption and formation. And those are the osteoclasts, which are the bone cells that are responsible for resorption, and then the osteoblasts, which are the cells that are responsible for formation. And the healthy bone is the result of healthy balance between resorption and formation. So in essence, every 10 years, we get a new skeleton as a result of this resorption and formation caused by the osteoclasts and the osteoblasts. So when we're dealing with a healthy bone, then we have the process is equal. And here they're using the word deposition, but its formation is another way of saying that. With osteoporosis, we actually get accelerated bone breakdown without a matching amount or percentage of formation. So we're left with a net loss of bone. And in some pathological conditions, there's actually too much deposition, which leads to very hard, brittle bone. But in tonight's talk, we're talking about osteoporosis, where there's accelerated bone loss. Now, so does that mean that bone loss is bad? Not at all. Bone loss is, as we've seen, is necessary and actually fulfills a couple of different functions. One is that it repairs the micro damage to the skin within the skeleton that occurs on a day-to-day basis normally, so that we maintain the strength. It also is necessary to have that bone breakdown on a regular basis to liberate some of the minerals, especially calcium, that is stored in the bones primarily. Like 99% of all the calcium in our body is being stored in our bones, some in our teeth, but mostly in our bones. But calcium is also a very critical mineral for many other metabolic functions, many other chemical functions in the body. And in the blood, if you remember, like when you have your annual physical exam and you're having a metabolic profile of blood work done, there's always, almost always, there should be a measurement of how much calcium is in your serum or in your bloodstream. Well, that calcium gets into your blood by this regular breakdown of bone on a microscopic level. And so that there's always a constant amount of calcium that's held within a very tight range in the bloodstream, available for other chemical reactions. So we get accelerated bone loss when there's either increase in the osteoclastic activity or a decrease in the osteoblastic activity, which leads to breakdown outpacing formation. And that's what osteoporosis is: accelerated bone loss, literally porous bone that is characterized by low bone mass, deterioration of bone tissue, which increases the bone's fragility and leads to fracture risk. And we all know how incredibly common it is in this, in the world and in the United States. But I want to just pause here for a moment and say that even though osteoporosis is very common, it is important for us to appreciate that it is not normal. And oftentimes, too many people, including a lot of clinicians, speak of osteoporosis as if it were a natural outcome of aging, but it isn't. Because if it was an expected outcome of aging, then we would all have osteoporosis, which is not the case. Now, many women do, and quite a few men do as well, but it's not normal. And so I want all of us to hear that, because if we go into this as we age with the expectation that osteoporosis is just an ordinary result of aging and it's just a matter of time, then there's no motivation there for us to address it and to think about what else we can do to minimize it. And the lack of bone mass or bone mineral density is really not the issue here. What is the issue is that the outcome of low bone density is the increased risk for fracture. And that's the problem, where there are up to 25% of the people who experience a hip fracture die within that year of that fracture. And about 50% of the people, of elderly people who have hip fractures, never regain previous function, have to lose some level of independence in their daily living, and it severely affects their quality of life. That's the risk of poor bone health, is the fracture risk. But I do want everybody to understand that even though osteoporosis is common, it is not normal. There is a lot that we can do to minimize our risk to poor bone health and subsequent fracture. One of the best ways to support our healthy bones as we age is to develop and hit peak bone mass in our earlier years. So this is another indicator of what your fracture risk might be, is that if you were in a situation in your first, second, and maybe into your third decade of life where you did not have the opportunity to maximally create peak bone mass, then that's the total amount of bone that you have to work with the rest of your life. I kind of make the analogy to the peak bone mass is your opportunity is the result of all the deposits that you put into your bone bank up until your 20s and your 30s. And then at that point, no more deposits are accepted. What's in the bone bank is what you've got to work with. And we can see from this chart that, we hit peak bone mass for men and women in between our 20s and 30s. And then it starts to decline very slowly. And then because of the hormonal changes associated with menopause, for women, you see that quick dip starting in the 50s to the 60s, and then that levels out again. So there is decreasing bone mass with age, which is inevitable, but doesn't necessarily need to result in osteoporosis or fracture risk. What can contribute to peak bone mass? There is certainly a genetic component to that, but also the research shows us that young adults in their teens through their 20s and into their 30s, if they're participating in doing some regular resistance or weight-bearing exercises and having adequate calcium and protein, that's what contributes to your peak bone mass. So remember, we talked about that inner structure, that trabecular bone being minerals embedded in that protein collagen matrix. That's why protein intake is so important during the formative bone years that lead to peak bone mass. Things like smoking, alcohol, and lack of good nutrition during those bone formative years will have an impact on peak bone mass. But let's talk about what the primary risk factors are for osteoporosis. We've talked about not being able to really capitalize on developing peak bone mass in our 20s up until our 20s or our 30s, but also individuals who have a low body mass are at risk for osteoporosis because of the lack of muscle, as well as slight skeletal build, contribute to, which result in a low body mass index, will contribute to osteoporosis. We're well familiar with the lack of exercise or a sedentary lifestyle. Certain key nutrients, calcium, magnesium, D, K, as well as inadequate protein, we've already alluded to. Excessive alcohol use will also impact our bone health, as will smoking. And genetics are a factor as well. If there's a family history of osteoporosis, sometimes noted for the first time when you have a parent with a hip fracture, for example. Menopause we're well familiar with in terms of the hormonal changes. It's speculated that women lose about 10% of their bone mass in the first 5 years of menopause. So we want to do everything we can to minimize that loss as much as possible, and then continue to be able to safeguard the bones health that we have in the postmenopausal period. But there are also secondary factors that contribute to osteoporosis. And this is the area that I find is not as well evaluated or considered by both the public and or practitioners. There are hormonal imbalances that can lead to estrogen and testosterone deficiency. I think of women at elite athletes who are working their bodies and working out so hard that they actually stop cycling with a regular menstrual period. and then also in chronic cases of chronic inflammation that are manifested in a lot of autoimmune diseases, whether that be rheumatoid or psoriatic arthritis or Sjogren's or lupus or celiac. Kidney disease is going to affect our bone health because of most likely interacting with our vitamin D and our calcium levels. Parathyroid and thyroid conditions will also impact not only, for example, thyroid conditions themselves, but also the medication that is necessary for individuals who either have hyper or hypothyroid conditions, if not managed well, can contribute to bone loss, premature bone loss. And then we have issues related to poor digestion or malabsorption, things like the inflammatory bowel disease or like ulcerative colitis, and then or even irritable bowel syndrome, where malabsorption and poor digestion is a big factor. Diabetes, it will also affect our bone health, as well as some cancers. And then another big category that I see are the side effects of certain medications. And this is an area that I think is also getting very underappreciated. So for individuals who use glucocorticoids, I see a fair amount of that in my practice as a chiropractor, where people are being prescribed steroids to manage their inflammatory musculoskeletal issues, which is a dangerous thing because even within a few weeks of using those steroids like prednisone, for example, it reduces the body's ability to absorb calcium, and it increases the rate at which bone is broken down, or how quickly the bone resorption factors happen. Another big medication area is the protein pump inhibitors, things like omeprazole and its relatives that are used for symptoms related to GERD or indigestion or reflux. Long-term use of these protein pump inhibitors have a dramatic effect and actually increase between the steroids and the protein pump inhibitors. Well, as well as anti-seizure medications are going to actually put us more at risk for osteoporosis, and some high blood pressure medications as well. Now, some of these medications some people might feel like, well, I can't go without them. Well, in some cases you can, by being a little more proactive, perhaps around taking care of health issues before they get to the point where they need these medications, addressing digestive issues that can help get at the root cause of the GERD or the reflux. Certainly some things like anti-seizure medications may be necessary, and for sure, for a lot of people who are dealing with epilepsy for different reasons. That means at least then, if we know that those medications are going to have an adverse effect on our bone health, then that can kind of motivate us as to safeguard our bone health even more, make sure that we're eating in a way that gives our body the nutrition it needs to maintain and build bone. So how do we evaluate bone health and osteoporosis in particular? You know, there are some signs and symptoms that one can be familiar with. The stooped posture that comes from pronounced thoracic kyphosis, what we call fragility fractures that happen with minimal stress to the system, like after bending or light lifting or, stepping off a curb or even coughing can create a fracture. That's when we have to suspect that there may be some loss of bone density. There can be some symptoms that are associated. There are times when certainly those of us who work with the body might want to be suspicious of something like a compression fracture, and pain that can be that people experience in their lower lumbar, in the hip, in the forearm, or the wrist. But you know, what's interesting about all of these signs and symptoms is that they are late indicators of bone health. By the time these symptoms or signs are showing up, you probably have already lost a fair amount of bone and are easily fracturing. And so that's why it's so important to do things like assessing fracture risk by doing certain questionnaires or the FRAX questionnaire online to look at what are the elements that might be putting you at risk. What's your family history? What is your nutrition? What medications are you on? All of those things can help give you a heads up as to what your risk assessment might lead you to believe your bone health is compromised or not. The true gold standard that's been used to look at bone health has been the DEXA scan. And the purpose of the DEXA scan was never meant to indicate who should be treated or not for osteoporosis. The DEXA scan was designed to have some sort of standardized measurement of bone density, which it does do quite well. But I want to just remind people that measuring bone mineral density is just one part of the equation. It's not the whole picture that gives us information about your bone health or your risk of accelerated bone loss. But as far as a way to measure bone density, it is very reliable. There can be some shift in your measurements from one bone density facility to another, which is why I oftentimes recommend that you try to use the same facility that for repeat DEXA scans, so that you get the same level of technology. But you probably are familiar with reading your DEXA report talking about T-scores and Z-scores. And T-scores are your measurement of bone density compared to an average bone density of a 30-year-old, either man or woman, depending on you're still of the same sex. Whereas a Z-score is an adjusted score comparing your score to someone of the same age and the same sex. We use the T-score to determine whether your bone density is within normal limits, or is it osteopenic, or are you actually at an advanced level of bone density loss. And so the scoring system is, as you see here, if it's -1 plus, then that's considered normal. If it's -1 to -2.5, that's considered low bone density, which is labeled osteopenia. And I just want to remind everybody that osteopenia is not a diagnosis. It is just a description of low bone density. And if you happen to be of slight build, Scandinavian background, you probably are going to be identified as osteopenic, but that doesn't necessarily mean that you are at a greater risk of fracture. And that's important to remember. If you score on your T-score greater than 2.5 or below, then you do have porous bone that can lead to fracture. and you probably will be prescribed a medication as an option. We're going to talk more about those. And we're also going to talk about what you can do naturally to support your bone health and improve your bone density by 40% or better. But one of the problems with the DEXA scan is that how often is that done, right? At most once a year, and more likely once every 2 years. And so that's a long period of time to go to get a follow-up assessment of whether what you're doing is making a difference or not, right? So the beauty of some of these other lab tests here, they're called bone formation markers and bone resorption markers, is that they can be done much easily every 3 months, every 6 months, at the same time that you're having your DEXA scan, so that you have other measurements available to you to help see if your bone resorption markers are going down or your bone formation markers are going up. Now, the other thing that these tests are good for too is that many of these tests are a result of looking at metabolic markers that come from the protein collagen matrix that we were discussing earlier. And remember that the DEXA scan only looks at mineralization of the bone. So now here you've got, if you're doing any of these tests at the same time that you're doing a DEXA scan, you're getting a much more comprehensive picture of your bone health. So I encourage you to ask your doctor about them. They typically are not, they're very underutilized within conventional medicine. Frequently, the only time they are utilized is when you're being monitored for how the efficacy of any of the bone medications, pharmaceuticals that you might be recommended to take. But any licensed practitioner can order these. And so I do a lot of work with these other tests with some of my patients where we're working on bone health issues. And for all of those reasons that I just mentioned, we get a much more immediate feedback on how they're doing with their program. We see the numbers changing, which indicates we're on the right path. Or if those numbers don't change, then it tells me, okay, we need to find out what else is going on here. And this might be some of the other labs that are beneficial to do when we're looking at bone health. Chronic inflammation accelerates or activates the osteoclast activity. Osteoclast activity, you remember, has to do with bone breakdown, right? Or resorption. And so there's a very easily measured C-reactive protein that will give us a clue as to whether your body is dealing with chronic levels of inflammation. It doesn't tell us what the inflammation is due to, but it does tell us that your body is dealing with higher levels than normal of inflammation, which then will have us ask the question of, well, where could that be coming from? And that might lead to some other investigations. Vitamin D is easily measured these days, and it's important for osteoblast differentiation or working of the bone formation specialty cells. And then there's a variety of other hormones that are important as well that get measured, perhaps. So there's lots that you can look at from a gathering data point of view, other than just making all of your bone health decisions just on the basis of a DEXA scan. So let's talk for a few minutes about the current conventional treatments for osteoporosis, which are primarily, you will be offered, be sure to take 1,000 milligrams of calcium and some vitamin D, although they might not be willing to check your D level, but and get some weight-bearing exercise. And the only other recommendation comes from the prescription pad, right? Which is couple of different classes of medications are on the market now that looked hopeful originally, but subsequently are not looking as favorable for a lot of different reasons. So the oldest group, the bisphosphonates, slow the bone resorption by reducing osteoclast function. You might be familiar by the names of them are called Fosamax or Reclast, Iridia, or Boniva. And what has been found is that these drugs are, the benefit of reduction of fracture is beneficial for those who already are osteoporotic. It is not for primary prevention of osteoporosis. It is for secondary prevention of a second fracture. And there are a fair amount of side effects associated with the bisphosphonates. And so much so that up to 50% of the individuals who start these medications do not continue with them because of the adverse side effects. The second group, the newer class of drugs, kind of go under the umbrella term of anti-resorptives, and they work in the opposite manner. The previous group, the bisphosphonates, worked on preventing bone resorption, whereas the anti-resorptives work on building formation, okay, the anabolic effect. Both of them have some problems associated with it because then it was hopeful initially because with the anti-resorptives like Forteo, for example, they found that there was a substantial increase in the bone density. But because of potential side effects, it was only recommended that it was used for 2 years maximum. And then in order to not lose the benefits of the anti-resorptives, people needed to be on one of the bisphosphonates for the rest of their life. Otherwise, you lost all the gains. So that was kind of a short-term solution in having to do with bone health. Now, you know, it's kind of like we're going back to the past, when back in, 15 plus years ago, the Surgeon General gave a report, which was, the following recommendation, which was at the foundation of bone health and fracture risk reduction was to work on the lifestyle of having to do with nutrition and physical activity and fall prevention. And then if that didn't adequately address the issues and improve bone health, then you would start looking at what are some of those underlying issues that might be preventing the bones from getting what they need, and working more on what we call in functional medicine root cause. Were there digestive issues? Did somebody have chronic inflammation that hadn't been addressed? Were they also a poorly controlled type 2 diabetic, taking medication that was working on their blood glucose and their insulin excellent, but also contributing to poor bone health? Was this also happening with somebody who had autoimmune issues that needed to be better managed or controlled? And then only as a very last resort do we think about pharmaceuticals. So I would like to suggest that we go back to the base of this pyramid and to the second level as well. So we deal on the basic lifestyle habits of nutrition and physical activity and improving balance and minimizing falls risk. And then also looking at that second level of what else is sabotaging your bone health that we need to address. And so that leads me to really working on a lifestyle approach, which I consider to be the foundation. And the goal of an effective bone builder plan is to restore balanced bone remodeling. Remember, we want to have We want to identify what the unique factors are that might be causing excessive resorption and or eliminating or minimizing the effect of those factors, like poor digestion, somebody needing to be on a PPI, or chronic musculoskeletal issues that could be addressed differently so that they didn't need as many doses of strong anti-inflammatories like steroids, and to ensure the nutrient needs that will maximize osteoblast activity. That's the goal. Those are the goals of how to restore balanced bone remodeling. So let's start with the nutrition piece. There are 4 key nutrients that are really critical for bone health. There's the vitamin D, magnesium, and K, and calcium. And the first 3 are, by many different measurements, most people in this country are deficient or insufficient in those 3 nutrients. Most people may not be blatantly deficient in calcium, but their consumption may be insufficient. And what saves most of the population is that many foods are fortified or enriched with forms of calcium. But let's look at what these 4 nutrients do, because I think I referred to the calcium phosphorus mineral complex is oftentimes referred to as hydroxyapatite, and that gets embedded into that protein collagen matrix. So calcium is the major player in that hydroxyapatite density, and calcium also alone helps to suppress bone resorption. Vitamin D helps with the intestinal absorption of calcium and phosphorus, and it also helps to limit the loss of calcium by the kidneys. Vitamin K, K2 in particular, is important to decrease osteoclast activity. That's the bone resorption. And it also helps to keep calcium out of soft tissues where it's not useful to us, where it actually can create problems, especially if the soft tissues happen to be major arteries to the heart, in the heart, and to the brain. This was speculated that calcium being broken, bones being resorbed in an accelerated fashion was liberating too much calcium into the bloodstream, and without enough vitamin K on board, that calcium was going into soft tissues, which was actually contributing to cardiac risk for women, postmenopausal women. Magnesium is important because it's used almost everywhere in the body. It helps the vitamin D to move from an inactive to an active form. It increases, it's not a key player in quantity, but in terms of it's necessary to help increase that hydroxyapatite density and structure. And it's also required for vitamin D, K2, and bone metabolism. So 4 key nutrients that you want to make sure you're getting enough of them on a daily basis. And that's these totals that you see here. I would change that 1,000 to 1,200 for postmenopausal women. And I would make sure that you understand that these totals are a combination of what you might be supplementing with, as well as your food sources, okay? And that's especially true with calcium. A lot of women have been overdosing with calcium because they're taking 1,000 or 1,200 milligrams of calcium as a supplement. And in addition to that, they're eating 400, 600, sometimes 800 milligrams of calcium through their daily food intake. That's way too much calcium. And especially if you don't have enough vitamin K2 on board, then your calcium is going to find a home where it's not really beneficial to you and cause problems like in the cardiac region. There are some specialized nutrients that we want to address as well, though. And these don't get as much press, and I highly recommend the use of these as in a supplemental form because none of them are really very available in foods, or you have to eat too much of those foods in order to get the dosing that you're looking for. But anybody who has a diagnosis of osteoporosis should be on a supplement that includes the 4 key nutrients as well as these specialized nutrients. Let's look at what they do. So boron has some very interesting beneficial effects. Not a whole lot of human trials, but there's very good data on osteoporotic fats, which I know isn't always the best way to get our information, but this is what we've got to work on. But the results are very favorable here, which is that boron was shown to increase magnesium absorption. It helps us to hang on to our calcium, and it reduces other inflammatory biomarkers. So very good to have this trace mineral on board for bone health. The ipriflavone is a phytonutrient frequently derived from soy that enhances osteoblast activity and inhibits bone resorption. And it's found to potentiate the effects of estrogen on bone and to induce calcitonin, which is a hormone produced by the parathyroid gland. It's actually been marketed as a pharmaceutical in other parts of the world for treatment for osteoporosis. And there have been many trials with it. One of the initial ones was in a good 12 years ago. There was a 12-month randomized controlled trial, a small group of 60 postmenopausal women. They had one cohort was just on vitamin D and calcium, one was just on ipriflavone, and the other was a placebo. And what they found is that the bone pain these women had was relieved, and that their bone mineral density increased, and that they had significant improvements compared to either the vitamin and calcium group or just the placebo. And so much so that in other parts of the world, they use ipriflavone as a safe estrogen replacement treatment. Since then, there has been 11 more studies with over 1,000 patients showing the benefits of ipriflavone in combination with calcium. And then finally with strontium, it's a trace mineral that's very similar in its chemical structure to calcium. It is very effective at stimulating that osteoblast formation in the bone marrow, and it also increases bone mineralization, and it reduces osteoclast activity. So it's going to reduce resorption and boost osteoclastic bone formation. 2 important studies that were found with looking at the benefits of strontium was a combination of micronutrients that was done with women for 1 year who either declined pharmaceuticals or had basically drug failure with the pharmaceuticals. They did a combination of strontium, D3, K2, magnesium, and an essential fatty acid called DHA. And what they found is a significant improvement in bone mineral density in both the spine, the hip, and the femur. And it was as effective as the bisphosphonates, but there were no fractures associated with the use of strontium. Another study used a combination of strontium, D3, K2 again, but now with melatonin, and found that there was increased bone mineral density with both the femur and the spine, and that the bone turnover markers were decreased, indicating that there was reduction of bone resorption as a result of this formula. So, and in Europe, there's a type of strontium that's been used for several years with great efficacy on reducing fracture. The only thing that I would, so strontium in supplement is valuable, and the only thing that I would recommend with strontium is if you're going to look at a formula to give you that for support, is that you take the strontium at a separate time from your calcium, because remember, they are very similar to one another, and so they almost like absorption is interfered for both of them. So you want the better pharmaceutical, the better supplement companies will make a morning package and an evening package, and the morning package will have the strontium in it, and the evening package will have the calcium in it. You really don't want to take, you're not going to get the benefits of strontium in your formula if you take one pill that has both calcium and strontium in it at the same time, okay? And of course, there's always extra nutrients that are extremely valuable. And most of these vitamins and minerals, the reason they are included in formulas, or that we want to make sure you're getting enough of them in your daily food plan, is that they help the key nutrients do their job better. So it really, the days of just calcium alone, or just calcium and vitamin D, are long gone. Well, I talk about, if you're going to do a supplement, you need to do a supplement for that we would categorize as bone food, something that has many of these nutrients in it in order to support, give your bones what they need. So here's the other nutrient that we really need to talk about too, is protein. Because that protein that we eat on a day-to-day basis, and we should be getting close to 46 grams per day, more if you're recovering from an illness, or if you're dealing with a wound, or just had surgery. But 46 grams for women per day, 56 grams for men, ballpark, is critical to support that protein-rich collagen matrix. It doesn't have to be animal products. It can be vegetable products as well. So, but vegans and vegetarians have to really be on their plan. You have to make a point of ensuring that you're getting adequate protein given the lack of animal product. So that inner matrix needs protein. And there are definite studies that show positive association between bone mass gain and protein intake. If you don't get enough protein, then that leads to decreased calcium absorption, and also there's a inverse relationship between incidence of hip fracture and protein intake. So I can't impress that enough, that for many people trying to do the healthy thing in their diet by doing more plant-based foods, I am all in favor of that, because those plant-based foods are rich in the vitamins and minerals, many of them that we need for our basic healthy metabolism, but specifically bone health. But having a plant-based diet doesn't necessarily mean inadequate amounts of protein. So we just need to pay attention to that. Oops, excuse me. So when we talk about what kind of diets do we need to do? What kind of food plan do we need to do in order to boost our bone health? Well, you can see all of those vitamins and minerals. Well, where do they come from? Most of them are going to be coming from the vegetables and fruit and the colorful foods in our diet. The diets that are most well known that can provide the nutrient base that supports bone health are frequently the Mediterranean diet and also the paleo diet. But anything that is providing you with an anti-inflammatory food plan is going to do the job. So you want a higher intake of vegetables, more so than fruit, I would say, with nuts for the healthy oils. And if you're going to do meats, fish, chicken, you need to make sure that they are good quality, grass-fed beef, free-range chickens, no hormones, wild seafood, etc., to really benefit from your animal products. Well, then the other foundational piece of bone building, isn't it, is exercise, and specifically resistance exercise, which is a little different than weight bearing, which is what we've been told for many years. But resistance exercise actually is so much more beneficial because it's much more specific and it multitasks. Because if we're doing healthy, appropriate, resistive exercise, we're not only building bone, but we're also building muscle. And the two go hand in hand. So by doing what we call osteogenic loading, we're adding weight or impact onto the bone to build more bone because it stimulates the chemistry of the bone to make itself stronger. So we want to increase our mechanical strains within reason. And one of the ways to do this is resistance exercise to strengthen the bones. And there's lots of different ways of working with this. If you're not a gym rat, you don't particularly enjoy working out at in the gym, then do something different. Go dancing, put on some great music. For people who are interested in yoga, Lauren, you might want to follow Lauren Fishman's work. He's an MD in New York who did a study on looking at 12 specific yoga postures and actually did studies that showed that the women who did his program, I believe, I don't remember now, I think it was a year, that they did these 12 specific postures 3 times a week. They actually showed a reversal of improvement in their bone density based on DEXA scans before they started the program and after. His work is really very available on Google. If you Google his name, you'll come up with his book and a lot of yoga magazine articles that perpetuate his work. I had a laugh because most recently, that was the benefits of hopping. One-legged hopping was actually shown to elevate bone mineral density. So jumping rope. If you're pressed for time, there's the high intensity interval training, which can make a huge difference in muscle mass development and subsequently bone health. And then also one of the developments that I'm very excited about and learning about and curious about is blood flow restriction, sometimes called BFR. And what I'm excited about it the most is that it is a very safe way for people who are dealing with past fractures or who are healing from surgery or trauma or have other types of physical limitations, don't need to lose bone mass. They can still exercise safely and build muscle as well as bone. So I'd like to rename this webinar A Lifestyle Approach to Bone Health, because I think we need to start thinking about what to do about bone health before we get to the point of osteoporosis. I hope you'll agree, and I hope you found this helpful.
That was great. Thank you.
I am going to stop sharing my screen. That's great. Look at everybody here. Hello, everyone. All right. Now, I think people are unmuted. Is that correct? No. Why don't you go ahead and let's take a look at where do I find the chat here? Let's look at that. I'm having trouble finding my chat box. Here we go. Where is that? Well, I'm sorry, I don't see my chat box anywhere. Can everybody unmute themselves so that you can, and why doesn't somebody go ahead and ask a question? Oh, Deb, I can't hear you. It doesn't look like you're muted on my end, Deb.
I can't hear her.
Yeah. And this is maddening because if I can't see my, let me try to minimize this. Nope, that's not it.
You don't have a chat button?
Yeah, I'm not seeing it.
So I was going to ask a question. What's your thoughts on soy and osteoporosis? I always hear.
So the iproflavone is an example of a soy item, and it has very good track record with bone health. I think soy has gotten a bit of a bad rap because it got referred to as a phytoestrogen, and mistakenly got referred to it, well, not mistakenly, but it limits the understanding of what soy can do. Soy does not necessarily cause dangerous elevation of estrogen. It is more of a modulator. And based on the iproflavone studies, it looks like soy can be helpful for bone health.
Oh, okay.
Provided that it is a non-GMO source. Yeah.
Thank you.
Now, having said that, let me clarify, which is that I think that soy, there's soy and then there's soy. So soy as it exists in its natural form is best. So edamame or fermented soy, natto, great source of vitamin K, tofu, tempeh. What I'm not comfortable with is people eating soy hot dogs, soy hamburgers, soy, you know, everything is soy. That I'm concerned about because I think there's not enough variety in the diet and you're overloading the system with too much of the same thing, which is never good for any of us with any particular food product. So So that's my caveat to the soy.
Can you hear me now?
I can hear you now.
Yeah, I remembered I did that work thing for such a long time, and I had the headset over at my desk. I have a question. I mean, I have osteoporosis, and I'm in the really firmly in your lifestyle category, doing all of those things and not doing the things I should have be doing. I want to hear where you're going with this workshop.
With the master class?
Yeah.
Yeah, sure. So, so a couple of things. One is that, information is good, but information is just for information's sake is not that helpful. What I want to help people do in this upcoming masterclass in January is have a core group of committed folks who are interested in doing a deeper dive into their bone health. So we would evaluate, well, what are you doing? What aren't you doing? Where is there room for improvement? What are you doing for supplementation? What kind of exercise are you doing? And then if all of those are checked off as good, then we start looking at, okay, what else is going on for you that's interfering with your bone health? So do you have digestive issues? Are you for some reason not digesting your food and absorbing your nutrients the way you need to? So despite doing all these other healthy lifestyle habits, what's happening is that you're not getting the benefit of the majority of that because of maldigestion or malabsorption. Are you on any other medications, and what are they, and how do we find workarounds for them that would be less impactful on bone health? And sometimes the testing that I refer to is helpful. In fact, what I'm thinking about doing and want to try to figure out how to make this happen is to offer a panel to people in this master class, a panel of lab tests that will complement your DEXA studies, so that, and to give us some additional clues about, because there might be some gold mines of information in that arena as well. So that's where I'm wanting to go with the master class, is to help people really do a deeper dive into their lifestyle habits so that they support their bone health at whatever level of bone health they are at, as measured by their DEXA scan or their fracture risk, but then also to help people who are struggling with, like, why aren't my DEXA scans improving? I'm doing A, B, and C, and nothing's really shaking out. Well, what else can we do to do a deeper dive around that? And what are some solutions for that?
That's exciting. As I said, I'm firmly in the osteo, and there's a genetic component, but I was shocked at how fast I was sent to a specialist, and he wanted to put me on medication. I mean, it wasn't even a conversation. And then I did the research after and said I had follow-up questions, and they're just not used to that. And I'm like, you know what? I'm going to decline that for now. But they put you on, and they don't tell you this is a lot, the rest of your life commitment. They're not, that's shocking.
I think there's some unfortunate lack of communication and not the awareness that there should be. And part of it is there are no other tools from their perspective, and so that's why I want to share this kind of information, so that other people, men and women, understand that there are some other tools that they might want to access.
Thank you so much, and I will continue following.
Excellent. Good. Betsy?
So I'd like to know if you have a bone supplement that you really suggest.
Mm-hmm.
Is there a 2-pill or a 3-pill that I can pick up at Common Crow?
Yeah, so that's a good question. And what I have done is made different protocols based on where you are with your bone health. So, you know, the first goal is to get what you need through your food. That's kind of step one. But then in addition to that, oftentimes there are limitations, or you just, like, as you saw with some of the those other specialized nutrients, you can't eat enough of a certain food because it's so it's not as plentiful as a food source. So I've created some protocols for different levels of bone health, and I can share that with you and with the listeners here today. And give you some recommendations of, because I work with my own online dispensary called Full Script, and I have protocols in that online dispensary that can be helpful to, you know, if you have good bone, if you have a good DEXA scan, if your bone mineral density is within normal, but you're looking to maintain, this is the group of supplements you want to look at. If you're got okay bone health, but you're maybe osteopenic or you have a family history, then we need to ramp up your supplement maybe and give you some of those more targeted nutrients. And if you're osteoporotic, then maybe you need to look at this formula that has more of the key nutrients that are going to help rebuild bone, encourage the bone formation. So I can include that in your packet of materials that you'll be getting. I guess tomorrow, right, Christina? We're going to be sending an email out to everybody, everybody who's here tonight and everybody who registered, and I will give you a link to that Full Script online dispensaries with directions, if necessary, on how to filter through the different products.
Yeah, hopefully by the end of the day tomorrow, if not Wednesday morning, I'll have that
Great.
out.
Great, thank you. Good. Any other questions at all?
Hi,
Sandy?
Susan. Could you talk a little bit more about the BFR and its relationship to?
I can. I'm not the most qualified to speak on it, but one of the things that will be part of the master class will be looking at some innovative new developments that are happening in the world of physical medicine and exercise, looking at things like BFR, blood flow restriction. And I've been doing blood flow restriction program for maybe 6 months now. And it's a way of improving. It's first was designed in Japan, I think, with their weightlifters, who they would put cuffs, pressurized cuffs on their upper arms and on their upper legs, their thighs, top of their thighs, and then do their workout, their resistance exercise with these cuffs in place. Those cuffs would restrict blood flow, not totally, of course, but significantly, to the point where you would get greater benefit from the workout with lesser weight. Sometimes just with your own body weight, instead of a 20-pound weight, you could get the same quality of a workout with a 10-pound weight. So there were better workouts, they were more effective, and there were fewer injuries. And what they found over time is now they're starting to look, and what they found is that that whole blood flow restriction phenomenon, chemistry in the body, would liberate a whole hormonal cascade that would accelerate muscle mass development. And it's also being seen now to accelerate bone mass at the same time. So what I'm really excited about is using this technology with people who are not, who are frail and may not be in as good physical condition, but they can use this I don't know if technology is the right word, but they can use this form of working out, sitting in a chair and just picking a leg up one after another and build muscle and benefit bone at the same time. So part of the master class would be a guest lecturer with PJ O'Clair, who is one of the innovative leaders of bringing blood flow restriction to the North Shore. And so she would be coming to one of these masterclass meetings when we're focusing on physical movement and exercise, and have an opportunity to pick her brain about it and ask more questions. But it's really pretty amazing. I've been following my own improvements and that of some of my colleagues who I've been working out with, and it's been pretty interesting. So thanks for asking, Sandy. Christina.
I have a question. What do you recommend for an age that you should get a baseline of some kind, whether it's the DEXA or all the other tests? And then how often should you, just to see where your bone health is?
Yeah, that's a really good question. And unfortunately, the DEXA scans are not being done early enough to give us a baseline that gives us any valuable information about what to do differently. So the recommendation right now is that the first DEXA scan gets done when you're 65. Is that right, Linda Ann? I believe so.
I don't know about that one.
Yeah, I think that's what I've read in my studies here. Now, there is a possibility that if you have been on long-term steroids, or if you have autoimmune issues like celiac or unexplained fragility fractures much earlier in life, hopefully that would trigger a clinician's thinking to go, I wonder what's going on with your bone mass. Let's do a DEXA and get a baseline. But that typically is not, unless you're willing to pay for it out of pocket, you're not going to get a DEXA scan until you're 65, which is how many years postmenopausal is that for a lot of women? And it's not typically done for men.
Right.
Unless they have some really presentation of, like I said, a fragility fracture. So,
What should they be?
When should there be?
When should the baseline be?
Well,
Ideally.
what about in your 30s or your 40s when you've reached peak bone mass and you want to know what do you have to work with, right? Because if you were, what if you didn't have access to good nutrition growing up? What if you had gut issues where you weren't absorbing nutrients? What if you had or diagnosed with celiac when you were 12 or 14? So all of those health conditions are going to compromise your body's ability to maximize your peak bone mass by the time you're in your 20s or your 30s. So my way of thinking is, if we want to know what a bone density baseline really is, we should do it before we hit 45, so that we know what we've got to work with. And then maybe backfill with some of those other bone turnover tests to kind of keep us in the loop about where are we going, you know, are we building bone or are we continuing to lose bone? And not have to wait 2 years until another DEXA scan.
I have a question about that. Is it okay, my turn? Okay.
Yes.
I'm echoing, so I'm sorry. Am I echoing for you as well? Okay. I'm horribly predisposed to osteoporosis with my family history. So I started being checked when I was about 45, starting to go through the change. And it's not terrible, but I've been managing it with diet, and I've been taking prescriptions as well over the years. So that's all I knew of until this talk. So thank you.
You're welcome. And I think that, do you think that from what you heard tonight, that there might be some other things that you might take advantage of?
I think it would be good for me to create a checklist to see what I'm doing, because I do most of that. I'm pretty active. My diet is goes in line with what you're saying. But I would also like to find out, there was a comment from Laura about, is there a formulation available for vitamins and minerals? Because you've given us, I've taken massive notes, but I'm not a chemist. So that was a question for you as well.
Okay, so yeah, stay tuned to the email that you get tomorrow or Wednesday that will have a link to the different formulations that so you can compare what you might already be doing and how it's, you know, what you might want to shift around in order to hit those key nutrients.
It's perfect. There's always room for improvement. So I thank you for that.
Great, good, good. Jenny.
Hi, that's my mom who just talked. So we're here together.
Nice.
And I had a question, and this is something my mom and I have talked a lot about, is protein intake, because I think it's really easy to, in our busy lives, to just not, whether we're eating more plant-based or not, to just not eat enough. And I see that a lot with people that I work with as they age. It's just hard to eat enough sometimes. And your recommendation for protein was a little bit lower than what I've generally have worked with. And I just wanted to see like where that was coming from. How do you suggest people get enough protein when they may not want to be like looking at the grams of everything and like micro, you know what I mean? Like, do you have general guidelines that you tell people?
So I usually do a little bit more of a detailed jump into this. So I don't usually, for this purpose, I just gave kind of like a general ballpark. But when I'm working with people individually, or like in the group, if with the masterclass, we would look at determining what your actual protein need is based on some metrics that we would do. And then we would multiply that by a certain number of grams. And that's what your unique amount of grams per protein per day would need to be.
Okay.
And then we would make sure that and then we would go over, well, what are your dietary preferences? What do you like to eat? What kind of protein foods are you inclined to go to, you know, do you eat eggs, or do you do chicken, or, you know, so, and then basically like, this is how much chicken gives, this much chicken, 3 ounces of chicken is going to give you X number of grams. And so then you kind of just piece it together from there in terms of how you tend to eat throughout the day. But then also looking at, you know, we've got the food taken care of from the protein, but you know, then are you digesting your food well? And are you getting the benefit of that protein? Right? So that's like other questions that we ask to try to really maximize. Every step you want to take needs to have a payoff. We want it all to pay off. We don't want any wasted effort with all this work that we're trying to do to stay well. Right?
Yeah.
Did that answer your question?
Yeah, it did.
Okay.
Thank you.
Good. Yeah. All right. Well, if there are no other questions, I really appreciate you joining me tonight. Thank you for your attention and your thoughtful questions. And I hope you have found it helpful and have found ways to maybe make some subtle shifts that will have big results for you. And you will be kept in the loop. You'll be the first to know and learn more about the masterclass that I'm working on in the new year. So, so stay posted, and you can also keep up with what's going on by subscribing to my blog posts at harborhealthgroup.com, and also following me on following Harbor Health Group on Facebook. So, but we'll be in touch. Thank you so much for your attention this evening.
Thank you. Bye-bye.
You're so welcome.